Awesome.
Well, hi, and welcome back to a very special episode on this channel. We're going to talk today about all things related to mast cell, particularly from the viewpoint of an allergist, immunologist. I have a friend and colleague, Dr. Kara Wada, who's here. Two Karas, what could be better than that? Thanks for joining us.
Thanks so much for having me. Yeah, I was trying to think of some cute ways to capitalize on the fact that it's like the two Kiras, coming together. I don't know. For some reason, Captain Planet was coming to mind. We a few of our other colleagues together.
That's right.
Um, yeah, I'm a both a pediatric and adult allergy, immunology, and lifestyle medicine physician. Done some additional training in functional medicine, and I recently opened my own practice, the Immune Confident Institute, earlier this year, which really focuses on taking care of those patients who are somewhere on the spectrum between allergies and autoimmunity. And I think, as we've talked offline, a lot of the same, we're seeing a lot of the same folks dealing with complex chronic symptoms that don't read the textbook, at least how the
Hmm.
textbooks are currently written, who are
Hmm.
really finding a hard time being seen, heard, and believed within the medical system.
Yes, absolutely. I think that is the perfect way. I think folks find you and me for those same reasons. They're looking for a place where they can feel safe, feel heard, and get some answers to some symptoms that no one else seems to have the time or understanding to deal with. So, my question to you on behalf of the folks who follow this channel is in this mast cell POTS EDS triad that I know that you and I both see a ton of, folks are looking for not only an answer, sometimes a diagnosis to explain their symptoms, but sometimes people have never even heard about mast cell disease before or what that spectrum looks
Yeah.
like. And so as we start to work them up, often patients come with questions. They're like, I've listened to TikTok, I've done my research, I want these tests done. Can we start just by talking about the tests and how that
Yeah.
can be problematic in making a
Yeah.
diagnosis? Yeah.
So mast cells are immune system cells. We often will refer to them as allergy cells, though there are a couple different types of cells we term allergy cells, but they're a primary one. And they're the ones that are responsible for things like hives, itching, swelling, wheezing, in large part. And so these cells have preformed packets of little granules that are bioactive in them. And there are dozens, if not hundreds, of different types of chemical mediators that are in these
Mhm.
cells. And they're just ready to be used if the situation calls for the need. And so these are substances that we can measure either in the blood or in the urine, that can give us a rough idea if these cells are behaving normally or if they are misbehaving.
Mhm.
So one of the main tests that will come up in the conversation is a blood test called a serum tryptase. It is a level that we have ideally loved to check within about 4 hours of a systemic or anaphylactic allergic reaction because it's a way to confirm, in large part, that this was an episode of anaphylaxis as opposed to another cause for those symptoms. The reality is, though, that even in anaphylaxis, that level is not always elevated. So, and I
Mhm.
think it's somewhere around 20% of cases of anaphylaxis, and in particular, food-related allergy, that level actually will not bump up. It's also been a pretty good marker for a couple of other conditions, one called systemic mastocytosis, which is most often related to a mutation in a particular receptor on these cells called the KIT receptor. And these folks will have essentially some changes in how these cells look and behave, even down to like the bone marrow. So I
Mhm.
tell folks mastocytosis isn't cancer, but it's like
Mhm.
one half step closer to cancer than not,
That's right. Yep.
because there is like this mutation and kind of some of these bone marrow changes. There also is a condition or a newly described entity called hereditary alpha tryptosemia, which is a huge mouthful, so we call it HAT for short.
Mhm.
And we've realized that about 6% of the population has extra copies of the gene that codes for tryptase. So when you check a tryptase level, they have extra copies of the gene, they're making more of it at baseline. And we think that perhaps this, may increase the likelihood of allergic symptoms in situations, but not always. Some of these folks are walking around, they have no idea. They're doing fine. And then the reality is not a perfect test. And so the other tests that we can check for are urine markers, and they are for a long time, it was required that you collect urine for 24 hours. You had to keep that urine incredibly cold, ideally on ice. So you can imagine that would be a little challenging if you're trying to like put all of your urine from a day into the container, keep it cold.
Yep.
And then you would have to bring that jug to the lab. And if you're someone who has to hydrate a ton because you have POTS, dysautonomia, sort of things, you might be needed more than one jug to accommodate for that. Um, and we check for three different markers. It's called a leukotriene metabolite, a prostaglandin metabolite, and a histamine metabolite. The great news is that all of these tests have now been, the testing has been updated, and now we can do it from a single urine specimen as opposed to that whole day's worth, which
Mhm.
is a whole lot easier. And so when I send someone to the lab, I tell them, like, hey, ask the lab tech to get you some ice before you go into the restroom to provide your sample so that you can put that sample directly on ice. That also provides some insurance for if that lab tech gets busy and forgets about it on the counter, that you have some wiggle room for it to stay cold while they get everything packaged up to be sent out to the lab that actually runs the tests. But those can be really helpful in teasing out if we have biochemical, markers to say, yeah, it looks like your mast cells are more active than the average person. Often I will order these at baseline. So kind of on a regular
Yeah.
day. I don't recommend that patients stop their medications before doing these tests. The one exception is if someone is on high dose non-steroidals, aspirin, which most of our patients are not on those, that can falsely lower the prostaglandin level.
Yep.
Um, but risk benefit in regards to deciding whether to do that or not with your individual clinician. And then often, if they're normal or negative, we will have a discussion of like, well, is it worth repeating them when you're more symptomatic? And or, in the meantime, and we kind of mentioned this before we hit record, I'm often suggesting that we're trying some interventions to help them
Mhm.
symptomatically to see how they go because so many of the tools in our toolbox are like the benefit versus the risk is
Yeah, they're so
almost
benign. Yeah.
overwhelmingly in the benefit
Yeah.
category.
Correct. Correct.
Yeah. Yeah.
Exactly. Yeah,
Yeah.
I equate it often to being hangry. Like if you're feeling hangry and you eat food and you feel better, I don't need you to prove to me that your blood sugar was low. And so mast cell disease is very much the same way. If you're having flushing and sun sensitivity and digestive issues and all these things that may activate the mast cells and all these food triggers, and I treat you with antihistamines and some mast cell stabilizers, and you get better. It's at least for me what I'll document in the chart is clinical diagnosis of mast cell disease, even if the biochemistry, the labs, and the biopsies are normal.
Yeah,
So
I've taken a similar approach, and I think this is where things get a little heated in some physician circles because certainly
yep,
there is a spectrum in folks' willingness to rely on their clinical skills. And
yes,
and I've kind of talked about this a little bit, but our generation of physicians, and frankly the generation before us and the ones that are coming up after us, we have been really so privileged in having labs, having imaging at our
hmm
fingertips. And
right,
so if I think back to my grandma-in-law who has since passed away, but she went to medical school back in the 40s and 50s. She practice very hands-on medicine.
that's
I've
right.
talked a lot with my father-in-law. He remembers as a kid going to the office. She was a general practitioner, and he said, she would spend an hour with the patient talking, getting that history, really relying on those clinical skills to make the diagnosis.
Yeah.
And we don't get to flex that muscle. We don't allow ourselves to flex that muscle. And frankly, the system doesn't allow us to flex that muscle. So it
Yeah.
feels really icky sometimes
Yeah.
to wade into that gray zone and to say, oh, the labs may not be black and white, but goodness, this sure quacks like a duck. It has,
Hmm.
feathers and a beak, and like the
Yeah.
the treatments work. Like, let's just call it a duck. And
Yeah.
if something else comes along that changes our mind down the road as science evolves and the patient's symptoms may change, then so be it. But I run into this same brick wall. For instance, with Sjogren's disease, it's
Yeah.
similar that there
Yeah.
are a lot of folks that are seronegative, normal blood work, and so much reluctance in giving someone a label and providing treatment.
That's right. So you mentioned Sjogren. So what are some of the things, if someone suspects they have mast cell disease, that you would want to make sure that they've ruled out? We can say, this is not what that is. This
Ah,
is confirming. It's a rule out process. Any
yeah, so
thoughts
I
in your
think one of
practice?
the first things is thinking about mastocytosis in part because there are some more targeted treatments for folks that have that KIT mutation that
Mhm.
may be helpful, especially if their disease is quite severe. Other things that often I will be thinking about, and sometimes it's not an or, but an and. Um, is there some autoimmune disease going
Mhm.
on? Certainly, you mentioned kind of off the bat, is there hypermobility that's playing a role, dysautonomia, or changes where the automatic nervous system is not reading the textbook? And then, you know, are there instances where there is more um, true allergy? And that gets into the weeds a little bit, but there, are some scenarios, like for instance, alpha gal, which
Mhm.
is a tick acquired allergy where folks will develop allergic symptoms anytime they ingest mammalian meat, primarily meat products, but sometimes dairy and other related mammal-based products. And what makes that challenging is those symptoms are not always terribly clear cut because you can eat something and not react for several hours, which is
Later.
atypical.
Yeah.
You think of a peanut allergy, you
You
essentially
react immediately.
lick
Yeah.
the peanut and you're reacting.
Yeah.
There's a delay and some variability in how reactive folks are that it muddies the waters of it.
Yeah. I hear you. So ruling out autoimmune stuff, looking at connective tissue disorder, looking at
Mm,
dysautonomia. Exactly.
yeah. And
Should these
alpha gal
folks?
if
Yeah.
the shoe fits.
Yeah,
And other
exactly.
exposures, frankly, I'm still kind of opening my mind to the impact of mold and exposure to
Hmm.
mold and other, um, tick-borne diseases that,
Yep.
frankly, through my straight and narrow training, we're always very much poo-pooed. And you see enough patients,
Yeah.
symptoms and or who've benefited from treatment that it does just like go, like,
Yes.
what is actually going on here? And
Yeah,
how
I
much is that?
absolutely. Back to your grandmother-in-law, I think you called her.
Mm-hmm.
Like taking an amazing history and being a detective is such an important part of helping these folks. And I can't tell you the number of patients who have been like, I was fine until I moved to Georgia. I'm here in the South where there's a ton of mold.
Yep.
And I felt terrible. But when I go on vacation and get out of my home that was built in 1980, I feel great, right? And so it's really I can't underscore enough, like, I can put people on dozens of medications, but if we can't get down to those triggers, which really comes into that detective work, like, none of this stuff is really gonna fully resolve that, and, yes, I recognize it's a recommendation of privilege, but I have a patient recently who's just like, "I can't stand Georgia anymore." She moved back out to Arizona, and she emailed me, and she was like, "I feel amazing. It's, like, the best I've felt in years." So, that's an extreme example, but, yes, there are things in our environment and with foods.
Yeah. I
So
hear that a lot from folks in Eastern Ohio where there's
yes.
a mining, fracking, oil history that frankly we don't know what all is in the environment.
Yeah. Yes.
Spills.
Yes, for sure. Is there a role for allergy testing? Do you recommend these folks go through either blood or skin testing for allergens?
So we can extrapolate a tiny bit from the data on chronic hives. So not everyone with mast cell disorder has chronic hives, but I think of them as birds of a feather in
Mhm.
that chronic hives is a condition that most often is autoimmune in nature. It occurs for more than 6 weeks, most days of the week, and and it's a syndrome where the mast cells are being activated more
Mhm.
often than they should be.
Mhm.
And when we look at those patients, typically allergy testing is not super fruitful in identifying triggers that are driving those mast cells to auto destruct.
Yeah.
Um, my practice is I tend to avoid skin testing these folks because if they are getting symptom relief from their antihistamines, the last thing I want them to do is to hold their antihistamines for a week, throw themselves into a flare, and for when I go to do those skin scratch tests, that scratch on its own is very likely to trigger some of those
Yeah.
mast cells, and everything's going to look positive.
Yes, that's
So
right.
often the story I'll get from patients that have gone to see their local allergist, um, and have asked for allergy testing or have been offered. And frankly, allergy testing is a way that as allergists we make money. So
Mhm.
if you go to an allergist, especially a private practice allergist, not to throw them under the bus, but you very likely will get skin tested because it
Mhm.
helps keep the lights on. Um, that being said, what I'll hear often is everything was positive.
Mhm.
But then I went back and they said everything was negative. And what is the
Yeah,
reality?
that's right.
So
That's right.
often, if there are things that, we think might be, or they have a history of being a pretty allergic person, I often will default to blood work because blood work does not require us to stop medications. And
Mhm.
it gives us a really great snapshot to say, are you allergic or not? From the idea of allergy being an IgE protein or an antibody protein, and it's a flavor of memory that our immune system can make to
Mhm.
various triggers. Um, I will caution that food allergy testing is it's really critical to be thoughtful about the use of food allergy testing. Most people who have environmental allergies, if you do a broad food panel on them, you're very likely to find some positives.
Mhm.
But when you ask those patients, how do you do when you eat XYZ food? Overwhelmingly, it's not an issue. So there are a
Mhm.
lot of folks who will have what's called sensitization. They'll have a positive IgE test, but their reaction to the food is normal. So I
Yes.
caution because it can often lead to more restriction
Yes.
and nutrient deficiencies, malnourishment, all those things. So you know,
Yes.
be thoughtful with that.
Yes, which is, as you know, how I got into this work through the eating disorder lens, and it gets real obsessive real fast. Perfect.
Yeah.
Before we close out,
Hypervigilant.
any other pointers that you think patients who are seeking care, either in advocacy or things that they should
Yeah.
know as they go through this process?
Um, I would say if you are connecting with an allergist, talk with their front desk staff. Get the skinny, like figure out who locally will listen. And I think one of the big green flags to look out is to look for a physician that's happy in their practice.
Mm.
Because if you are encountering a physician who is busy and burnt out, they are not as able to tap into that empathy and to tap into that right side of their brain, which is what you really need in these
Yep.
instances.
Yeah.
And I think that plays into how gaslighting happens, and it doesn't excuse it, but it provides some, I think, perspective and ability to kind of see the other side. You also can ask the staff, how long are you scheduled with the doc? And that will give you an idea of the amount of time you're actually going to have and if
Yeah.
that is sufficient or not.
Yes, this is where I think Facebook groups and other social media, as much as people may say, oh, TikTok is so annoying, I think in these social networks, people are saying who's good, who's spending time, who's listening. And so I'm just really grateful that you've built a practice that I mean, I've seen you through this whole process. You are lighting up when you talk about the work that you do, and you're scaling, you're building, you're growing new, bringing on new docs. So that is a testament to how happy you are in your own practice. So thanks for sharing your wisdom with us today.
Oh, thank you so much.